Hey everyone, welcome to another episode of the Rad Review. It's going to be a total Mondo Rager. We are discussing radiology for the resuscitationist. My name is Rupal Jain from the University of Maryland School of Medicine, and this is episode number 8. I decided I wanted to address the CT perfusion confusion. All right, so let's start off with a case. We have a 47-year-old male, previously healthy, independently living, who is presenting to the emergency department with a witnessed onset of right hemiplegia, aphasia, and left gaze preference. His NIH stroke scale is 19. What do you want to do? Well, you're probably wondering, what is the time of onset? Unfortunately, it's about 8 hours ago, and his modified Rankin score, given no previous disability, is 0. My question to you is, what is the preferred test at this point to evaluate for his stroke symptoms? All right, great job to those who paused and answered correctly or guessed this answer choice because it was answer choice C. The correct answer is a CT of the head without contrast, plus a CT angiography of the head and the neck, plus a CT brain perfusion. Answer choice E is incorrect, as MRI and MRA are currently just too slow to be part of the standard evaluation of an acute stroke in the emergency department. So as you know, each of these different types of CT scans has its own individual purpose and function. Starting with the CT of the head without contrast, this is arguably the most important and is going to be the initial test, as it allows us to differentiate between hemorrhagic and ischemic stroke. By changing the windows, by the way, we're actually able to get a suggestion of where the ischemic stroke has occurred by identifying areas of cytotoxic edema. Now, the CTA head and neck shows us the vascular anatomy and helps us to identify vessel lesions and large vessel occlusions contributing to the ischemic stroke. All right, and now the CT perfusion scan. This is the new kid on the block causing some confusion. Why does this scan matter? The CT perfusion scan allows us to identify tissue that is irreversibly dead versus that which is salvageable. So all of that area of cytotoxic edema, which you could see on the dry CT of the head, we want to know how much of this edematous affected area is core infarct, dead tissue that can't be reversed, versus which of this tissue is ischemic penumbra, or tissue that can be salvaged by appropriate revascularization therapy. So think of the CT perfusion as allowing widening of the reperfusion time window, as our young, otherwise healthy male patient is now going to be offered potential therapy by opening up a vessel, restoring blood flow to the ischemic penumbra. We are potentially reversing some of the functional damage that we are seeing on exam. Okay, so we have our patient who has arrived to the triage door with ischemic stroke symptoms, a high NIH stroke scale, and he's outside of the window for thrombolytics. I want to go through what his initial evaluation looks like and how exactly a CT perfusion is performed in combination with CT and CTA. So maybe you meet this patient at the door and perform a very focused history and physical, including an NIH stroke scale. Maybe meanwhile, someone is checking a fingerstick blood glucose. Maybe someone pages a level 2 stroke or somehow alerts radiology and neurology that the patient is here and needs an emergent scan. Maybe meanwhile, someone obtains a CTA compatible power injectable line and the patient is off to CT. Now, before I jump into the details of how a CT perfusion is performed, let me preface by saying that this is just one of several protocols out there. I wanted to review at least one protocol in detail so you can hopefully understand what this test entails and why it can seem to take so long. So first, the patient undergoes a non-con CT head. Then the technician will power inject 40 milliliters of contrast. Remember, power injection is a rapid push at 4 to 5 milliliters per second in a 20 gauge or larger IV, ideally in the antecubital fossa. The contrast will pass through the brain tissue, causing transient hyperattenuation. This generates a time attenuation curve, as shown below, for each voxel of brain parenchyma studied. So here are some of the important parameters gleaned from this curve. This is the time it takes for hyperattenuation in the tissue to peak. This is how you calculate a mean transit time, or essentially the time it takes for contrast to move from arteries to capillaries to vein. And cerebral volume, which is the amount of blood present in the tissue, is found by calculating the area under the curve. So this time attenuation curve is determined for each voxel of brain parenchyma, which, as you can imagine, would be a lot of radiation and a lot of subsequent data generated. For this reason, CT perfusion is done in either one or maybe two slabs. Only the area in each slab is radiated and studied. The first slab is usually at the level of the basal ganglia, as the ACA, MCA, and PCA territories can be visualized on this slab. Now, fancier CT scans can complete an additional slab just superior to this slab. The technician must be very careful to avoid any overlap of the slabs to minimize double radiation to any brain parenchyma, and also must be careful to avoid any gaps in the slabs in order to avoid missing a stroke. Then the technician must wait a few minutes before power injecting an additional 70 milliliters of contrast for the CTA head and neck. Finally, the CT perfusion software analyzes the data. Essentially, this is the time attenuation curve for each voxel of brain tissue, and then generates a color map based on this. There's two more data points obtained from these curves, and these are arguably the most important because they are what differentiate infarcted core from ischemic penumbra. The first is cerebral blood flow, which is obtained by measuring the slope, and Tmax, which is the time it takes to get to this max slope. Now, to conceptualize cerebral blood flow, think that this is the amount of blood flowing through the capillaries per unit time per unit tissue. When cerebral blood flow is low, this corresponds to areas of hypoperfusion, and specifically infarcted core displays decreased cerebral blood flow by 30%. Ischemic penumbra, on the other hand, only has a moderately reduced cerebral blood flow, and actually, what might even be a better distinguisher between infarcted core and ischemic penumbra is cerebral blood volume, which is severely decreased in dead tissue, but is near normal or increased in the salvageable tissue in the penumbra due to autoregulatory compensatory vasodilation. And secondly, Tmax is important because it, along with time to peak, mean transit time, are all increased in both the ischemic penumbra and the center infarcted core. By the way, different post-processing softwares are going to use different combinations of cerebral blood flow, cerebral blood volume, Tmax, TTP, MTT to define what is core versus penumbra. Don't worry about that. Let's focus on this one example here that I provided you of a CT perfusion map in which core is defined by reduced cerebral blood flow by 30%, and penumbra plus core will have a Tmax greater than 6 seconds. In this example, in orange, the total volume of tissue with cerebral blood flow reduced by 30% is 18 milliliters. In green, the total volume of tissue with Tmax greater than 6 seconds is 50 milliliters. If you subtract 18 from 50, you find that the mismatch volume, or the total volume of salvageable tissue in the penumbra, is 32 milliliters of brain parenchyma. Now, someone somewhere along the way in my training once referred to the brain as expensive real estate, so you can imagine that 32 milliliters of brain parenchyma can be quite significant. Going back to our patient, first, the CT of the head without contrast shows no hemorrhage. There is, however, loss of gray-white differentiation here, suggesting a left MCA stroke, which correlates with our exam. The CT perfusion is done next. As you can see, we have data from both slab 1 and slab 2. Slab 1 shows 0 milliliters of core and 10 milliliters of area that corresponds to penumbra plus core. Slab 2 shows 15 milliliters of core and 65 milliliters of area that corresponds to penumbra plus core. When you have data from two slabs, you must add to get the totals. Now, when you subtract 15 milliliters from 75 milliliters, we determine that our patient has 60 milliliters of mismatch volume, or total volume of salvageable tissue, that makes up the penumbra. Another way of looking at this is by calculating a mismatch ratio by dividing 75 by 15, which equals 5. Next, a CTA is performed, which shows a lesion of the M1-M2 branch of the left MCA. As an example, I've put up a sample protocol that demonstrates that our patient, who again had onset of symptoms 8 hours ago, NIH stroke scale of 19, pre-stroke modified Rankin score of 0, CTA evidence of large vessel occlusion, and now CT perfusion evidence of mismatch ratio greater than 1.8, and penumbra volume of greater than 15, our patient is a candidate for endovascular therapy. Our patient was transferred to a comprehensive stroke center where he underwent a successful left MCA thrombectomy. As you can see on this DWI MRI sequence, the infarcted area is much smaller than the area in green above. This case highlights the utility of CT perfusion in a suspected large vessel occlusion. I want to thank you all for tuning in to episode 8 of the RAD review. Hopefully, I have diminished some of your CT perfusion confusion. For this episode, instead of wrapping up with RAD review pearls, we're going to wrap up with RAD review pitfalls. Pitfall number 1, software may only count lesions greater than 3 milliliters on mismatch maps, so lacunar infarcts may not show up. Pitfall number 2, remember that CT perfusion slabs are mostly at the level of basal ganglia and therefore are going to exclude strokes in areas of the posterior fossa and superior cerebral hemisphere. Pitfall number 3, motion artifact severely limits data. Pitfall number 4, in seizures, the affected brain is hyperperfused, leading to the appearance of hypoperfusion of the contralateral side, thereby mimicking ischemic stroke. And the fifth and final pitfall is failure to recognize that a CT perfusion has an increased scan time and delivers more radiation to a concentrated section of tissue. In this table, you can see that compared to a CTA head and neck, the CT perfusion scans only 24 millimeters of brain parenchyma. This is compared to 530 millimeters in a CTA head and neck. In the CT perfusion, that small area of parenchyma is radiated for 4 to 6 times longer.